But we move on now to competency-based medical education, which next slide, please, which Dr. Sonal Saxena, who is professor and head of microbiology at Maulana Azad Medical College, will explain. Professor Sonal Saxena, please, your experience with competency-based medical education.
Thank you, sir. Thank you very much. So at the outset, I would like to thank Caho for this opportunity to interact. As a medical educator, it is always my passion to work in the field of medical education, and it is my kind of my second life, as you can say. So I'm a microbiologist in my first and a medical educator in my second. So I also work as an adjunct faculty, and 2 years ago I completed my fellowship in medical education with the sole aim of answering to the challenges which have been raised by Dr. Bhargav so well. So it's my pleasure to be with this elite gathering, and within few minutes, I'm going to take you through this journey of competency-based medical education. Now, what we understand with competency-based medical education is not new. The concept came approximately 60 years ago. So it's not a new field. It's not something which we've learned recently. But it came into focus because in 2019, the National Medical Commission shifted the MBBS curriculum entirely onto competency-based medical education. Now, in spite of all the challenges with the students being online in 2020, this curriculum was implemented and it was later modified in 2024 again. The curriculum was modified again based on the experiences that we had for these 5 years for our system. So I'm going to just take you through as to what the approach is. So basically, it is an outcome-based approach. Earlier, when we were talking about medical education, we never thought what is the outcome. We only thought that we have an education need to fulfill, and we are doing this education need as part of our daily requirement. But competency-based required an approach to training and assessment, focusing it specifically on observable competencies. Now, many of these competencies are certifiable competencies. Like, for example, in microbiology, there are 3 certifiable competencies. So I will tell you with a very small example. Earlier, hand hygiene has always been a very important part of microbiology training and teaching. But now it is a certifiable competency. So unless the teacher is very much sure that this aspect has been covered, assessed, and I have to do it repeatedly. So it is 3 times to be assessed before calling a person that yes, he is competent enough in hand hygiene. So the focus has simply shifted from a time-based training to a outcome-based training. So how does it differ from a time-based training? We still complete MBBS in 4.5 years plus 1 year of internship. What has changed is that I may have to align extra class, I may have to align extra session for a slow learner, but I have to make sure that within the time period that is allotted to me, I finish that training in such a manner that it is observable and measurable. So instead of relying on just time and experience, it emphasizes that the student has got this knowledge. So the key principles are first, as I said, it's an outcome-based approach. So what should the student know at the end of this session is become more important, and what they need to know rather than completing of the curriculum. So the specific measurable competency. Earlier, this term specific and measurable, what we call as the SMART. So it has to be very, very specific. What should the student know after this? And it should be measurable. And each competency should have a set of learning objectives, because the doctor does not have to be an Indian medical graduate, has to be a primary healthcare doctor. Now, this Indian medical graduate, or IMG as we call it in National Medical Commission, this IMG should be a good empathetic listener. It should be skilled clinically. It should be having certain set of knowledge and should have a attitude which is measurable. So all these competencies would require different learning objectives. So these skills have to be observable. Are they able to apply that knowledge? That means it has moved from just know to knows how, and from show to shows how, when we talk of skills and practical training. And it also becomes patient centric. That means that the graduates who come out, the IMG, is able to counsel a patient, is able to measure the blood pressure, and that's how the competencies are mentioned in the curriculum, and that's how the programmatic manner in which it goes to. Now, does anything change in assessment in CBME? Yes, it changes because the assessments have to be systematic and the learning outcomes have to be measured throughout. I cannot say that after 1.5 years or 1 year, I will measure. And if I find that the person is not competent, I will declare him non-competent. Throughout the year, I have to measure this assessment again and again, suggest an improvement that yes, you did 4 steps very correctly, but the 5th step was not right. Or what you managed, how do you manage the patient was correct in this manner, but not in this manner. So feedback has become a very important component of competency-based medical education. So has the various degrees of assessment. So for skill, you have a different type of assessment. For knowledge, you have a different type of assessment. And then there are clear benchmarks that if I assess here and I find that he is average or he's not good, then I track in the second session as to what I can do better. Then there is an entrustable professional activities or EPA. That means the student is able to demonstrate competence when they are going to work independently. And for this, they need to have a developmental dashboards. That means either they should have a chart or a logbook where the student progress can be tracked. Now, what happens is I've heard this many times from our teachers and my colleagues that the students carry too many logbooks, but logbooks are the basic tool of CBME. That's how you track what level the student has moved. And there has to be a continuous coaching and mentoring by providing feedback and guidance. We have to have a culture which needs to continuously learn and improve ourselves. And this is not, as I said, a new system. It was there in engineering from a very long time. It has been used in education for a very long time. And that's how now it has come up in our medical education as well. So the purpose is to have a better patient care so that they understand the most of the assessment is based on either simulated or real patients. And that's how they have to ensure that it's a high quality patient care. The assessment is more objective. You know, when you move to say an OSPI style or an OSCE style, it is more objective rather than being subjective. Very often the students complain, I wrote the same thing, but I was not given marks. I gave the same answers in Viva. So even our Viva now are a little structured. In microbiology at MAMC, we've structured their Viva questions also. We give them a case scenario, ask certain questions, and they do not allow the examiners to deviate too much from that level or from the competency that the student is required to know. And it gives them a little more personalized experience. The only problem here is you need a better teacher-student ratio to handle. If you have that, then probably the delivery and the assessment is very good. So the specific learning objectives for students and the outcomes for students makes it easier for them also to understand. If I display my learning objectives in the beginning of the session, the student know that by the end, we should be knowing at least these 1, 2, 3, 4, 5 things which have been written on that slide or have been. Now, what has NMC done in the past few years to enable all of us to implement CBME and to enhance teaching skill is that it mandates that each college should have a medical education unit. Now, this medical education unit, I am also a faculty and medical education unit at MAMC. So each medical education unit has got certain faculty members picked up from various departments, from clinical, paraclinical, all the departments, and they all answer to a state medical education unit or what we call as the Department of Medical Education which is a state center. And then there is a regional center. MAMC now is the regional center. And we have 3 or 4 states aligned with us. And again, we are answerable to the nodal center, which for us is CMC Vellore. So few regional centers. So it's a kind of a cogwheel kind of a thing. What is mandatory for teaching faculty is that they should have a basic education in basic course in medical education. It's a 3-day course with a completely structured program by NMC. Even the PPTs have been given by NMC. We can only change a few slides, not the content to a large extent. For curriculum committee members and for medical education unit members, it is mandatory that they should have done something other than BCME, like an advanced course in medical education, which is 6-month program, or FAMER, which is Foundation for Advancement of International Medical Education and Research, which is a 2-year fellowship, and also must have done a curriculum implementation support program, which, like BCME, is an NMC mandated program which is run in each college. But in order to be a CC or an MEU member, your BCME and your 2-day CISP should have been done from your regional or state center, not from your own college. In addition, whatever the colleges are affiliated with the state center, they have an NMC observer, which is posted from the regional center or from the state center to those colleges when they do their own basic course in medical education or CISP. Like I have been to Lady Harding, to RML, to Safdarjung from MAMC. That person's job is to observe as to everything has been done as per NMC mandate, and also to coordinate if they face any difficulty, and also to report to NMC as to what went wrong, what went right, what could have been done better. All that feedback goes, and only then the certificates are released by NMC. So with this, how CBME is implemented, I have covered this part. The rest is up to the subjects as to how it is taken up in each subject and in each specialty. So with a lot of thanks to my alma mater, that is Maulana Azad Medical College, where I head the department now, I would like to hand over back to Dr. Ashok RATTAN. And again, thank you so much, sir, for allowing me to be part of this discussion.
Thank you very much, Dr. Sonal. As you know, that competency-based medical education has now been adopted in India, and hopefully it will make persons better and more competent to be able to do it once it is implemented thoroughly everywhere.